2.
Right. Good day, everyone. Welcome to this session entitled COVID-19, the Great Disruptor. I believe it's session 76. In case this is not the right session you're joining. And it's a privilege and a pleasure to introduce this session. Firstly, my name is Ketan Deda. I'm the head of the Division of Pulmonology at the University of Cape Town in South Africa, where we've had a substantial COVID burden. And thankfully, our cases are receding. And we also have a very high burden of TB. And so it'll be interesting to chat about some of these aspects as we go along. Just to introduce my co-chair, that's Professor Ed Nardell, who's probably well known to most of you. Ed is based at Harvard, and I see for some technical reason he hasn't joined us yet, but I'm sure he will join us shortly. So we're going to go over to the first presentation, and that's by John Emery. And it's really focused on the Diamond Princess outbreak, and in many parallels with TB. And this issue of transmission and positivity in asymptomatic individuals, and we have so many parallels between COVID-19 and TB. But to tell us more about this, over to you, John.
Okay, so thank you very much for having me. I have no conflicts of interest to report. So this is a study trying to look at, apply the learning from modeling subclinical TB and applying it to asymptomatic COVID-19. So usually I'm a TB modeler, and I specifically focus on subclinical TB. So these are people who are infectious, but yet don't yet show clinical symptoms. Just as this epidemic was becoming a pandemic, people were asking very similar questions about COVID-19 they were TB. Both in the scientific journals as well as in the mainstream media. And so we decided to try and ask very similar questions of COVID-19, which is what proportion of infections are asymptomatic, because that has important implications for the extent of the pandemic so far, so how many people are infected. And in terms of transmission, how infectious are asymptomatic individuals and how much do they contribute to overall transmission, which has obvious implications for the effectiveness of interventions. And so trying to understand asymptomatic COVID-19, just like subclinical TB, can be difficult because we don't have information, or we have little information on people who don't have symptoms. But a natural place to test this in the early stages of the outbreak was the Diamond Princess cruise ship. It provides a closed environment with systematic symptom agnostic testing that can help us provide the denominator. So we tried to apply modeling techniques to understand the outbreak on the Diamond Princess and answer the questions I mentioned in the previous slide. Okay, so in terms of the methods, a quick timeline of the Diamond Princess outbreak. So it set sail on the 20th of January from Yokohama. After a tour of Southeast Asia, returned to Yokohama. But in the meantime, an index patient tested positive who had disembarked. And as a result, the ship was put in a 2-week quarantine beginning on the 5th of February. And there are essentially 2 types of testing during quarantine. And the first was symptom-based testing. So these are people that presented with, for example, a persistent cough, were given a PCR test, and if they were positive, they were removed and isolated from the ship. There was also, as testing capacity ramped up, though, symptom-agnostic testing. So this was systematic testing of individuals without symptoms. And most of this testing was performed in the final portion of the quarantine, so during disembarkation. And these are essentially the 2 areas where where we receive data in order to model. And so the symptom portion of the data is shown here. So these are symptomatic cases over time, where the left-hand line is showing the index case tested positive, and the right-hand line is showing the beginning of quarantine. And you can see on the left is for passengers, the right is for crew, with very typical epidemic outbreaks. Slightly higher amongst passengers and slightly later amongst crew. For the asymptomatic portion of the data, all of our information is coming from symptom-agnostic testing. And the testing profile is shown on the right-hand side and the results of that testing on the left-hand side. And you can see most of those tests are performed towards the end of quarantine. So this is the data we're using to model the outbreak. In terms of the model itself, there's 2 copies of this model structure, one for crew, one for passengers. And there's 2 important aspects of the model to talk about here. One is that we allow for pre-symptomatic infections. So that is people that then develop symptoms. And we also allow for asymptomatic infections, people who never develop symptoms. And we apply 2 types of testing. So people who are symptomatic removed from the ship from symptom-based testing, and we also allow for symptom-agnostic testing. And it's through those testing that we're able to try and match the data. We do that with a Bayesian MCMC algorithm, and we try and infer important parameters that can then try and answer the questions I mentioned in the introduction. So in terms of our results, so this slide is trying to show how well we're fitting to the data. It shows the epidemic. So the top row is the data I've already shown. And you can see we can fit to the symptomatic and asymptomatic data relatively well with a median and a 95% uncertainty interval. And to also draw your attention to to panel E, which is the basic reproduction number, which in this case effectively measures the strength of contact between individuals, which is all entirely fit by the data. Nothing has been put in by hand. And you can see it naturally declines amongst contact between passengers just at the start of quarantine, and then crew, the contact is reduced a little bit later. And that reflects the fact that the crew's peak was later than the passengers. So we're able to try and match the epidemic relatively well. In terms of trying to answer our question, so these are the two important parameters we estimated. Blue shows a 0 to 1 flat prior, and the red shows a posterior. And for the proportion of infections that are asymptomatic, we find a relatively strong peak around 3/4. So we're able to identify that proportion relatively well. For the infectiousness of asymptomatics, though, we essentially return the prior between 0 and 1 again. So we can't say anything about the relative infectiousness of asymptomatics with this model and this data. So what does that mean for the outbreak? So to have that proportion of asymptomatic infections requires a large number of undetected pre or asymptomatic infections. And this is because symptom agnostic testing was done towards the end of the outbreak. And so many of those infections were missed earlier on during the outbreak. We're also able to show a fairly skewed proportion of asymptomatic contribution to transmission with a median just under 0.7 and an interquartile range shown. But we also find a relatively long tail consistent with very little contribution to transmission. And that's because we weren't able to identify the relative infectiousness of asymptomatics. So to dig into this plot a little bit more, we asked the question, if individuals who are asymptomatic were relatively non-infectious, what would that mean for the net reproduction number for pre-symptomatic passengers? So how many people on average does a pre-symptomatic passenger infect? And it would need to be somewhere between around 15 and 29. So this is not impossible, but it is relatively high. So this is a scenario we'd have to accept if we were trying to match the data. So just a few reflections. So we find that approximately 3/4 of infections on the Diamond Princess were asymptomatic. The majority remained undetected, but may have contributed substantially to transmission. This parameter of 3/4 has been measured elsewhere, and it's fairly heterogeneous. But one important study is a statistical analysis of the Diamond Princess, which found around 18% for this proportion, much less than our 3/4. But this was a statistical model that, stated in the paper, didn't account for undetected infections. Whereas we show that with a mechanistic model, if we allow for undetected infections, we find a much higher proportion for this parameter. We were unable to identify the relative infectiousness of asymptomatic individuals, and this is a limitation of the study. Additional data on asymptomatic infections, for example, stratified by passengers and crew, or information on symptoms or serology after disembarkation may have helped inform the model further. And our model primary analysis assumed that symptom agnostic testing was random, but we know that high-risk individuals were prioritized. We showed in sensitivity analysis that this had a modest impact on this proportion. It brought it down to about 2/3. And we again may have had a significant contribution to transmission. So to conclude then, an important point is that our results, where we may have had a substantial contribution to transmission, are critically dependent on the setting. They're not a constant of nature. And so these results will apply to settings where there's prompt isolation of symptomatic infections, but there's little or no consideration for asymptomatic infections. And just to sort of signpost towards the paper that's now in eLife for anyone that's interested in further details, and just to finish by thanking the organisers, the funders, the London School, my co-authors, and the COVID-19 working group at the London School, who've had a remarkable response to the outbreak and were a pleasure to work with. So I'll leave it there, and thank you very much.
I have no conflict of interest of this study. And I'm Kazuhiro Chimura of Research Institute of Tuberculosis, Tokyo, Japan. Today, I'd like to talk about the effect of COVID-19 on tuberculosis patient notification in Japan. Okay, let me begin by talking about the background of this study. And the spread of COVID-19 and the related political and social responses, such as the declaration of emergency and various restrictions like stay-at-home campaign may affect tuberculosis infection or tuberculosis disease. In addition, much of the work of medical institutions, local governments, and public health centers is being devoted to COVID-19 response. And there is a concern that it may compromise TB control activities. So my research question is, how affect COVID-19 to TB notification in the era of COVID-19? Method. We compared and analyzed the number of notifications of TB cases from January to April of 2019 and 2020 using the monthly report of TB surveillance in Japan. Result. First, let me show you the trend of the number of newly notified tuberculosis cases in Japan from January 2019 to April 2020. You can see a decrease in the number of notified TB cases in 2020. Especially, only 830 cases were notified in April 2020, and that was almost 3/4 compared with 2019. So we compare the number of newly notified cases from January to April 2019 and 2020. The number of newly notified TB patients in 2020 was 3,944, which represents a 12% decrease compared with 2019. The number of smear positive pulmonary TB patients was 224, which represents a 17% decrease. The number of latent tuberculosis infection cases was 1,648, which represents a 29% decrease. This slide shows the age distribution of newly notified TB cases in 2019 and 2020. A blue bar shows the 2019 and red bar 2020, and changing rate between 2019 and 2020. You can see the decreasing rate was increased with age. Here, this slide shows the number of newly notified cases by place of birth, 2019 and 2020. You can see that the 13% decrease in Japan-born patients, but only 1% decrease in foreign-born patients between 2019 and 2020. And among foreign-born patients, you can see 9% decrease in recent immigrants. That means entry within the past 5 years. But on the other hand, you can see 8% increase in immigrants stayed more than 5 years in Japan. Here, this slide shows the number of newly notified cases by mode of detection, 2019 and 2020. You can see the number of TB patients detected at routine health checkup in school declined from 37 to 18. That decrease of 51%, almost half. And the number of TB patients detected at routine health checkups in prisons and other social welfare facilities declined from 17 to 10, a decrease of 41%. Here you can see the number of TB patients detected via contact investigation. Contact investigation for household decreased from 79 to 66, a 16% decrease. In particular, those detected via contact investigation for non-family members, for family member means such as the workplace, school, medical facilities, etc. So the substantial decline of 57% from 141 to 60. So, okay, I'd like to summarize the main findings of this study. There was a significant decrease in the number of newly notified TB cases in the first 4 months of 2020 as compared to the same period of 2019. The substantial reduction in the number of patients detected via contact investigation, especially for non-family members, was worrying. This may be due to an increase in the burden of COVID-19 related work at public health centers, as well as to contacts of TB patients refraining from undertaking medical examinations. Okay, finally, let me introduce you to our website. We keep up to date on Japanese TB surveillance data. Please check out our website. Thank you.
I'd like to start by thanking you for joining this presentation on the impact of COVID disruptions on TB burden. So to start with conflicts of interest, this work was conducted as part of my honorary position at the London School of Hygiene and Tropical Medicine, but I am an employee of Sanofi Pasteur working on COVID vaccines. All other co-authors have no conflicts of interest to declare. So the presentation will be about the impact of COVID-related disruption on TB burden. So in the context of COVID-19 pandemic, we're seeing a deprioritization and disruption of care and prevention in other infectious diseases such as tuberculosis. But on the flip side, we're also seeing that physical distancing measures could potentially reduce transmission outside of the household. So what we wanted to ask was, could transmission effects of physical distancing compensate for TB healthcare disruptions? So the aim was to estimate the theoretical or potential impact and trade-offs of COVID-19 related social distancing measures and health system disruptions on TB incidence and mortality in China, India, and South Africa. So we adapted an existing age-structured dynamic MTB transmission model calibrated to country-specific epidemiology and demographic data for each of the 3 countries. And the baseline model is published in Lancet Global Health and also in Science Translational Medicine. The adapted model was changed to be able to explore the impact of potential disruptions to both access or delivery of TB health services, which we took a simple approach to modelling delivery, modelling it as a reduction in case detection and in treatment success. And we looked at 0, 20, 50 or 80% reduction in both of these simultaneously. And based on the best available information at the time of this research, we thought that the most aligned scenarios were 20% for China, 50% for South Africa, and 80% for India, but all were explored in the 3 different countries. Then we also explored the impact of potential reductions in social contacts, using as a baseline the country-specific age-wise contact matrices, and then 3 different scenarios of social distancing, so looking at reduction in those social contacts. And those 3 different scenarios were reweighted contact patterns to reflect differential reduction in contacts in work, school, transport and leisure and other settings. But we assumed that there would be no change in the amount of contact occurring in the home. And so these altered contact patterns gave us a low, medium or high change in social contacts. We explored all of the above as 6-month disruptions in early 2020, and we estimated the cumulative change over 5 years in TB incidence and in deaths compared to the baseline. So then to move to the results, starting with the change in TB incident cases on the y-axis, and then on the x-axis looking at reduction in contacts either low, medium or high. And then in terms of reduction in service, that showed as the colour in the bar graph that you'll see in a moment. So if we start with the low reduction in contacts, we can see that with no reduction in TB services, but with a low reduction in contacts, you actually see a decrease in the number of TB incident cases predicted over the next 5 years. And then with all the other scenarios of reduction in service, seeing an increase. And similarly for medium and high. So we projected that most scenarios of TB healthcare disruption would lead to increases in China. So this was specifically China over this time frame, except in the scenario of low disruption and high social distancing. And then if we compare the results from China to those in India and South Africa, we see that some scenarios in each country where the benefits of a reduction in contacts could actually outweigh the risks of TB healthcare disruption in terms of the number of incident cases predicted over the next 5 years. If we then look at change in deaths as an outcome for each of these countries, we can see that the potential benefit of social distancing is actually larger for incidence as an outcome than deaths as an outcome. And this is consistent finding between the 3 countries. And we find that the majority of scenarios project an increase in TB deaths. Then if we have a look at those scenarios where there's that greater reduction in service, so in TB service access, so 80% or even 50% of reduction in services, we see that a substantial health service disruption such as this sees an increase in the number of cases and in the number of deaths. And again, we see this across all three countries. But local epidemiology is important in terms of the level of impact. So we see in China, which is a more reactivation-driven epidemic, the difference by increasing the reduction in contacts is less than, say, a more transmission-driven epidemic such as India. Then if we have a look at the most plausible scenarios based on the current anecdotal information, in terms of additional deaths over the next 5 years, it could be predicted to be 6,000 in China, 95,000 in India, and 13,000 in South Africa. And the worst case scenario modelled would lead to, across the three countries, more than 200,000 additional deaths over the next 5 years, which is an 8 to 14% increase. So obviously there are several limitations to this. So we were looking at theoretical scenarios as more data emerge on the specific scenarios as the pandemic plays out. We can estimates and scenarios could be updated. We assume similar impact on detection and on treatment. We assume no biological interaction between COVID and TB. And we did just model a 6-month disruption, but in some settings that we may experience multiple lockdowns or a varying length as is being seen in many countries globally right now. So with additional data, with additional experience, we can alter the scenarios that are modeled. We didn't account for external factors which could increase rates of progression to TB disease. And we didn't look at in-country geographical heterogeneity, which has been highlighted by Chen in ERJ. This may be particularly important as countries move towards more targeted or localized lockdowns. So to conclude, the majority of scenarios project an increase in TB deaths over this 5-year timeframe. Substantial health service disruption sees an increase in both incidence and deaths in our projections, and the potential benefit of social distancing is larger for incidence than for deaths, and that considering the local TB epidemiology is important for the results. And the worst case scenario could be more than 200,000 additional TB deaths over the next 5 years. So the key take-homes are that the benefit of social distancing is likely to be outweighed by health service disruption, and that it's crucially important to maintain and strengthen TB-related health services during and after COVID-19. So just to briefly put our results in context of some of the other research that's happened, by other research groups, etc. So concurrent modelling work, our results are similar in terms of the scale of impact and the mortality versus incidence finding. One of the strengths of this research is the detailed exploration of the transmission and the contact matrices, and those in combination in the different combinations with the disruption to healthcare access. And as there is emerging notification data indicative of declining TB registrations with some recovery post-lockdowns, which are suggestive of TB care disruptions. But only time will really tell what may happen midterm. And as we said before, as information evolves, we can update these models. And so then just finally to reiterate the crucial importance of maintaining and strengthening TB-related health services during and after COVID-19. And to finish, just thanks to all of the co-authors who were part of this work and to you for listening. Thank you.
Good day, everyone. I will be making a presentation for the work we did in Nigeria, KNCV TB Foundation. On the impact of COVID pandemic on active TB case finding intervention in Nigeria, the KNCV TB Foundation Nigeria experience. I'm Dr. Dume Bertrand, the Executive Director, and this work was done by my central team, Dr. Sani Kiru, Ogamaka Victor, and Chukudubem, with support from our field staff across 14 states in Nigeria. Now, the picture here is actually depicting our mobile van. We call it the Wellness on Wheel. The clients seeking to be tested for both COVID and TB via our mobile Wellness on Wheel truck. KNCV Nigeria, cheerful taking a lead in TB COVID integration service response in Nigeria. We started the community integrated service in Kaduna and presently in Imo State. Now, Nigeria, as we all know, is one of the 10 countries in the world, accounting for 80% gap in TB case notification. The National TB Program had embraced active TB case finding strategies to address the increasing gap in TB case finding. For the past 5 years, the gap in case finding had actually stagnated within about 75%. KCV TB Foundation, actually, we are funded by USAID under the TB Local Organization Network presently. But before now, we had funding we call the WAS project, just prior to the lockdowns following the COVID pandemic in Nigeria. We rolled out 2 high-impact TB case finding intervention. We call it the TB Surge, where we stationed cough officers across high-volume sites across the states where we work, and equally use the awareness on wheel, the WOW truck, to start integrated campaign that actually spanned most of the states. But at the time where we started the WAS project, our focus was in Kano State. And the WAS projects, the target states then were 9 states in the country. Now, the rising COVID epidemic had actually disrupted health systems globally with great impact on developing countries. Following the lockdown, there are actually restriction of movement and everything impacted on clinic attendance and likewise active TB case finding within those facilities using our surge intervention across the sites that we support. Now, what we did here, the study was across 61 high-volume facilities in 9 states and communities in Kano State where we used the WOW truck. These are actually the states that we were supported through a grant from USAID in partnership with the APSA Associate. We implemented the TB Surge and the WOW intervention. We implemented for a period of 8 weeks for the TB Surge and 4 weeks for the WOW campaign. And the study was actually a retrospective one where we reviewed data across the TB cascade, looking at the clinic attendance, number of clients that were screened, number of presumptives that were identified, number of presumptives that were evaluated using GeneXpert and other diagnostic options, down to the number that were diagnosed with TB and enrolled on treatment. Now, during the TB surge effort, we have what we call the ComCare. We use it to record the data along the TB cascade in real time. And we analyze for trend along the TB cascade for 8 weeks for the TB surge and for the 4 weeks where we had a WOW campaign in Kano State. Now, looking at the trend line here, the first one by my left actually is the 8 weeks trend in OPD attendees screened, presumptive TB cases that were found, TB cases diagnosed, and those placed on treatment. You could see that just prior to the advent of COVID had actually came in, it was diagnosed in China. First case was in China in December, but the first case in Nigeria was actually recorded in 27th of February. But not until March that the government came up with a lockdown restriction in an attempt to contain the COVID pandemic. You could look at the trend. There was actually a flat decline in trend of clients seen in those facilities, starting as high as 37,000, as low as 17,000 by the 8th of February. We had been on downward trend. The number of, there was a progressive decrease in clinic attendance, presumptive TB cases identification, TB cases detected, and treatment initiation for the TB surge intervention. Looking at by the 8th week of March, 8th to 14th week of March, compared to what was recorded in 26th to 2nd of April, there was actually a decrease of about 63% in clinic attendance for surge, 64% for presumptive identified, 73% those treatment TB cases diagnosed, and 72% those initiated on treatment. And likewise, same was found for the WOW intervention in communities we worked in Kano State, with a decline of 67%, those that were enrolled, 89% presumptive identified, those diagnosed with TB cases declined by 87%, and those that were initiated on treatment declined to 89% within the 4 weeks period in March. Now, in conclusion, as I've already said, that COVID has impacted negatively on TB case finding in Nigeria as depicted in those analyses done across these 9 states that we worked prior to the advent of COVID. And these had actually impacted across all the indicators we've monitored, starting from clinical attendance to the TB cases that were notified from the national program. Now, findings from this study actually was very clear in showing decline in clinical attendance, presumptive TB cases identified, cases detected, and treatment initiation since the onset of COVID-19 and with all those restrictions in country. Now, we've actually adapted our program and coming up with new innovations to manage the challenges that COVID presents with the TB control program. And we're actually seeing opportunities that come with COVID that we should tap into it to mitigate the impact of TB case finding. We'll follow this with integrated approach to COVID and TB case finding, and never in time in the life of TB program that we've embraced electronic reporting system and e-platform to push our intervention across the states. And these are new opportunities that have come with COVID that we are sure that if we maximize this potential, we'll be able to continue to mitigate the impact of COVID on active TB case finding in Nigeria. Thank you.
Hello, good morning, or good afternoon, depending on where you are. My name is Chukwuebuka Ogu, and I'll be making this presentation of this abstract titled Willingness to Test for Tuberculosis Amongst Symptomatic Community Members in an Era of COVID-19. This is an exploratory mixed methods study from Anambra State, which is in Southeast Nigeria. I'm a tuberculosis surveillance officer for the World Health Organization. I'm based in Anambra State. So I have no conflict of interest to declare for now. So as a form of a background or some sort of introduction, Nigeria recorded her first case of COVID-19 on 27th of February this year, 2020. And it made quite some round in the media. But a few weeks thereafter, on 23rd of March, the country implemented widespread control measures against COVID-19. So essentially, Anambra State, which is a state of about 6 million people, based on national government directives, implemented widespread control measures against the COVID-19, particularly on 23rd of March. The sort of measures in question included things like lockdown of movements, closure of businesses, of schools, closure of places of worship and private businesses, as well as mandatory isolation for anyone suspected to have been exposed to COVID or have actually contracted the disease. A few weeks after that, about 2 weeks or 3 weeks after that, on 10th April, the state recorded her first confirmed case of COVID-19. So we quickly found that for April, our routine tuberculosis program monitoring data showed a significant decline. It was actually about 40% decline in the number of expert MTB-rich sputum tests done in April compared to the monthly average for between January and March. In other words, the average of the preceding 3 months prior to April was 40% higher than the number for April. So we sought to explore, using a mixed methods research, what could have been responsible. In other words, how was COVID-19 and the responses thereof affecting the willingness of symptomatic community members towards undergoing tuberculosis testing? So essentially, we used electronic methods for this research. There were widespread lockdowns in the country. People couldn't move from one state to the other. I mean, even health workers experienced difficulties navigating the lockdown situations to get to their workplaces. So the only option open to us was an electronic research. So we designed the survey on Google Forms and shared it with community linkage coordinators. Essentially, linkage coordinators are employed by the program and different partners to collect sputum samples from community members and even from patent medicine vendors located within the communities. So these were people that were in direct contact with community members all the time. So the survey was to try to elicit any change in community attitudes towards TB testing, particularly symptomatic members of the community, In other words, people who were coughing, who were losing weight for a long period of time, who had nocturnal drenching night sweats and weight loss, in addition to fever. So we report simple proportions of the attitudes from the community members, and then we conducted some thematic analysis to the qualitative aspect of the data, which essentially sought to gauge the attitude of the community members with symptoms of TB. So essentially, this was an electronic survey that was completed by the linkage coordinators. So in terms of the results, on the whole, 18 linkage coordinators responded to the survey. And interestingly, just on the right-hand side of the slide, the patients, the community members who had symptoms complained about increased transportation costs, lack of basic PPEs at the PNV outlets. And then there was a prevailing misunderstanding of the public health information, and it tended to affect the number of sputum samples that we had available for testing. People misunderstood some of the communication from the national government and from the disease control agencies of government, and it then affected their willingness to test. So although enforced movement restrictions affected the ability of persons to access care, a strong theme of fear, was actually emergent from the data. And we note here that 90% of the linkage coordinators reported a negative change in attitude towards TB testing. And this is from community members who actually had symptoms of TB. For some reason, they were afraid of undergoing a TB test. 61% reported that the patent medicine vendors were unwilling to collect sputum samples from clients obviously showing symptoms of tuberculosis, for which, by the way, the PNVs are being incentivized. They have been trained to do that job, but they showed some sort of apprehension towards collecting samples in an era of COVID. So clearly, community members consistently expressed apprehension or fear towards undergoing a TB test. At the back of this fear was the worry or concern of being diagnosed with COVID and subsequently forced into isolation, in other words, separation from family. And then, it was also making the rounds at that time that if you died whilst in either isolation or treatment, that even your corpse would be inaccessible to your family. So that sense of fear sort of beclouded the minds of people to the extent that even though they had cough, weight loss, fever, and night sweat, they were unwilling to submit their sputum samples for TB for fear that it may lead to a COVID diagnosis and then isolation, separation from family, and so forth. So essentially, this theme of fear was really prevalent, and misunderstanding, particularly of the communication of the interventions the government put in place in response to the COVID. So we found again that the use of some of the extreme language, like lockdown, like isolation, quarantine, the way these words were thrown about, sort of connoted a sense of fear in the population, and then affected the way they engaged with intervention that were put in place. So this fear had a negative knock-on effect on the willingness of community members to test for TB. So just to conclude and wrap up our thoughts, we found that the interventions that were instituted for COVID-19 response, but to a greater extent, the language and the means of its communication actually ended up affecting the willingness of community members who had symptoms of TB towards undergoing a TB test. We found that even community-based patent medicine vendors also developed a certain unwillingness towards collecting sputum samples for symptomatic community members. This unwillingness to collect samples was embedded in both fear and uncertainty about the outcomes should they send a sample that now returns positive for COVID. This is despite the fact that in Nigeria, sputum sample was not being used for COVID testing. We were using the nasopharyngeal and oropharyngeal swabs. So, but this sort of misunderstanding of the public health information created this fear. The PNVs also lacked PPEs, which was a legitimate excuse to fall back on for not collecting sputum samples. So with these points, we sort of made the conclusion that the interventions, but more so the communication of it created apprehension towards tuberculosis testing. Thank you very much.
Hello, good afternoon, everyone. My name is Enoch Kizito. I work with URC USAID Defeat TB project here in Uganda, and I bring you warm regards from my project as well as my home country. I'm privileged to be part of this first ever virtual union conferencing meeting, and I'm all eyes and ears to take lessons from this interaction. I have no conflict of interest to report. I'm going to speak to us about the use of virtual and community delivery platforms to prevent MDR-TB treatment interruption during the national COVID-19 response. And these are lessons from Uganda. The list of guys down here are the ones that helped me put this work together as co-author. In this section, we want to highlight the use of virtual innovations in the programmatic management of drug-resistant TB in the face of unprecedented emergencies. Like we all know, the WHO declared COVID-19 outbreak a pandemic in early March of this year. As such, Uganda instituted prevention measures through a nationwide lockdown on the 24th of March to mitigate the spread of COVID-19. In Uganda, the programmatic management of drug-resistant TB uses what we call the mixed model of care. In this model, patients are admitted for a short duration of 2 weeks to 2 months and allowed back home to continue with ambulatory care while receiving treatment from a nearby health facility. And this is what we call their peripheral DOT site. They do this on a daily, coming from home to the nearby facility. And once a month, they pay us a visit for expert review at the DRTB treatment initiation sites. We have 17 such sites in Uganda. So as a result of the lockdown, many patients with MDR-TB couldn't attend their monthly hospital reviews for clinical and laboratory assessment. We went ahead to assess the situation affecting delivery of MDR-TB services and instituted remedial interventions. What did we do? In the face of the lockdown, the USAID Defeat TB project with the National TB and Leprosy Program held virtual meetings with all the 17 MDR-TB treatment centers to plan continuation of care. In these meetings, we conducted virtual education about COVID-19, how it is spread, infection control measures, and what to do in case a case showed up. We increased provision of PPE, that's personal protection equipment, to healthcare workers. This was in form of N95 respirators and face masks. We deployed community treatment supporters to ensure continuity of directly observed treatment for our patients. These supporters were in form of household members, village health team members that support patients in taking their drugs because they wouldn't move to their peripheral DOT facilities for daily DOT. We also supported the expansion of community-based care to sustain monthly clinical reviews and hospital monitoring. Here, the healthcare workers from the MDR-TB treatment sites were enabled to go and review these patients who otherwise wouldn't have made it for their monthly clinical reviews. They would also do simple tests in the community, like hemoglobin estimation, visual acuity testing, as well as draw samples to bring back to the lab for hospital monitoring and other relevant tests as per the testing schedule. We also provided adherence support through weekly phone calls to all patients. This was by way of giving extra airtime to the focal persons of the different MDR-TB treatment sites so that they support patients through the period by checking on them whether they have adverse events, because this will impact on their adherence, whether they have made in position to receive their medication as prescribed by use of the expanded community system as outlined above, or whether they have any hindrance that makes it impossible for them to take their medication. We made sure that drugs were delivered to all these DOT sites to maintain adequate stock during the lockdown. What did we see? What we saw was, from some select sites, this graph shows MDR-TB drug deliveries and patient community reviews for them. We had over 100 healthcare workers who were oriented on TB, COVID-19 integration, and provided with N95 respirators and face masks. We saw that 204 patients attended their monthly reviews and had their drugs restocked. From this graph, you can see that of note, 135, that's 66% of them, had their clinical reviews carried out in the community by staff from the initiation DRTB facilities. We also had 2 newly diagnosed rifampicin-resistant patients who were linked to care. And as the lockdown went on, in one of our urban MDR-TB treatment initiation sites, we established what we called a satellite clinic. This clinic was for MDR-TB patients who are inmates in the biggest prison in the country. So the healthcare team would visit the inmates and review them from there, as opposed to the inmates coming over for review every month. In conclusion, we see that use of virtual platforms and community-based patient reviews with drug deliveries ensured continuity of care for patients with MDR-TB during the COVID-19 outbreak in Uganda. And we recommend that we consolidate the virtual coordination and community service delivery platforms to optimize provision of DRTB care. We acknowledge Ministry of Health, National TB and Leprosy Program, the USAID, Uganda, Defeat TB, MDR-TB patient site care teams, TB treatment supporters and community actors in TB care, and all the TB patients and their families. Thank you.
Hello, good afternoon. My name is Tatiana Ismagilova. I'm from Ukraine. I work for the NGO 100% Life as a TB specialist. I am going to present you the information on provision of social services for TB patients during quarantine regime based on our experience across Ukraine. In March 2020, the Ukrainian government introduced quarantine that limited the spread of COVID-19, though this should negatively affect TB treatment outcome and the number of TB cases lost to follow-up. According to the World Health Organization, Ukraine is a country with one of the highest rates of MDR-TB. In 2017, the prevalence of MDR-TB Ukraine among the new and treated before TB patients were 28% and 48% respectively. MDR-TB treatment outcomes in Ukraine are suboptimal. An analysis of the 2015 MDR-TB cohort shows that 60% of patients were lost to follow-up, which is much more than World Health Organization recommended target, 5%. It's obvious that quarantine will limit the spread of COVID-19, though this may affect the patients with live tuberculosis. In response to the emergency, the Ukrainian National TB Program and the project reformatted their activities to ensure continuous access to TB treatment and social support for vulnerable groups patients. In order to ensure the continuity of services, we have changed the approaches as to the organization and provision of the customers. In project management, we implemented the following. We carry out management remotely using online platforms and CRM systems. We organize distance learning for project managers in NGOs and social workers. We also hold regular online meetings with medical institutions, NGO, and partners. In the organization of provisional of services to NGO clients, we deliver TB treatment by social workers as well as ART for patients with co-infection such as TB, HIV. We control treatment remotely using gadgets. Comparing to the pre-quarantine period, the number of patients on the video DOT increased 3 times. We provide personal protective equipment for social workers who continue to control DOT to patients with a high risk of separation from treatment. We provide transportation of biomaterials of clients for diagnostics. We also deliver TB treatment drugs by mail or by courier. We used an innovative approach and we developed a mobile application for patients online registered in hospital or the national medical systems. Patients can make an appointment online and visit doctors without waiting in online and without contacting other patients. This significantly reduces the risk of contracting COVID-19. The implementation of new approaches in service provision led to the following positive results. The risk of COVID-19 contracting of patients with TB has decreased. Status as of September the 1st, 2020, 6 cases of TB COVID-19 were registered. Case of illness among social workers haven't been reported. The introduction of online communication made it possible to quickly respond to emerging problems with the involvement of central authorities. We should also state that during quarantine, we did not stop social services such as distribution of food packages, payment of expensive diagnostics, reimbursement of travel expenses, legal support, remote consultation of psychologists, and other such social assistance. Totally, we provide about 50,000 different services remotely, according to the second quarter report. In conclusion, we can say that after reformatting the project, we could reduce the risk of spread of COVID-19 among patients with TB. We can also state that the remote project management system can be effectively used in such interventions and in emergency situations similar to COVID-19 quarantine. The flexible approaches in the organization and delivery of psychosocial support to TB patients, which we effectively implemented, proved to be very important too. Thank you for your attention.
All right. Thank you. Thanks, everyone. Thanks, Ed, that you can join us. I'm glad you got through your technical difficulties. Ed, if it's okay with you, I will kick off with the dealing with some questions for talk one, which was by John Emery, and then I will hand over to you on the next one. Is that okay, Ed?
Sure.
Okay. All right. So, John, thanks. That was a great talk. And the first thing that I wanted to chat to you about was, implications of your work. And the thing that comes to mind is antigen-based testing. That's been a lot in the news recently. And despite having suboptimal sensitivity, maybe only 50 or 60%, people are plumping for the use now of, antigen testing. It's obviously quite controversial. And given, the scenario on the Diamond Princess, if such a testing modality was available, any insights or comments? Do you think it would have been useful? I'd be quite interested to hear your views on that, specifically or broadly. Thank you.
So we assumed looking at PCR testing on the Diamond Princess was the only form of testing that was done. And we looked at 100% sensitivity this was back in sort of March, April. So we had little data on sensitivity there. And so the implications there were, if we assumed a lower sensitivity, that presumably would have been lower in asymptomatics in particular, then our results would have been a lower bound. And so in terms of our results, the proportion that were asymptomatic and the role of asymptomatics on Diamond Princess we'd have measured it as being higher. That's the data that we had available essentially on the Diamond Princess, and any further data in terms of disembarkation, for example, and antibody testing after disembarkation wasn't available. So we were unable, in that sense, to pin the model down any further. In terms of wider implications. So this was really focused around from moving from TB into COVID-19. So since then we've been more back into TB. So I'm hesitant to comment more widely.
Right, and then just related to that, in your model, how did you assume or measure infectiousness? Did you make an assumption about that? And secondly, what about the duration of infectiousness? Did you make some assumptions about that as well? And what was that duration?
Absolutely, yes. So we had to make certain assumptions about duration. So we took the best prior data we had available at the time. So we assumed that people were symptomatic for about 2.9 days and pre-symptomatic for about 2.1 days, so 5 days infectiousness in total. And that was coming out of data originally from Wuhan in China. But in terms of asymptomatic duration, we didn't have any data on that. So we just assumed it was the same as for those who developed symptoms. But we did a sensitivity analysis, double and half that time, and it made no discernible difference to our
and what, if I can just chip in, and what proportion of individuals that were asymptomatic did you assume had, they would have all been shedding virus for 5 days, but did you make an assumption that a proportion of them would be highly infectious, if I can use that word?
So we just assumed everything was constant. So over time, people had the same infectiousness, and individuals had the same infectiousness.
Okay.
Again,
so that's just
our information.
Yeah, that's just looping back to the whole, antigen testing thing, because that's sort of the theory or the assumption is that, hey, although you have suboptimal sensitivity, it's a rapid test. You can test widely. You can test quickly. So even if you pick up half the people, doesn't matter. What you are going to pick up is those that are high viral shedders. So it was interesting to hear your perspectives on that. The final quick, if you can give us a quick answer, any thoughts on implications for these cruise liners going down in the future? People are getting back to holidays and things. It seems a perfect storm to transmit dangerous respiratory pathogen. I mean, if just broadly, what recommendations you make regarding?
Certainly the reproduction number we found, it was much higher than 3 that you might find in a community normally. So that suggests a lot of transmission, and that goes for any closed environment. Necessarily cruise ships, could be prisons or this is highly infectious and I mean, I'd be cautious.
Yeah. All right. Well, any other questions for John? Any other comments, Ed?
Yeah. Yes, actually. I'm sorry I joined late. I did have some technical difficulty with the two platforms here. John, I may have missed this because I was struggling to get on when you were speaking, but did you have a sense of transmission through the ventilation system versus person-to-person contact through this outbreak? Was there any way you could get at that question?
No, that's a really interesting question. Would like to have looked at in more detail. We didn't have data at the level of cabins, for example, where we could have looked at perhaps a more individual-based model to try and look at that kind of transmission. We just assumed a certain contact rate regardless of the specific transmission mode. So that would be really interesting.
It's kind of an important issue, and I'll just spend a second on it. Going back to the SS bird, there's lots of evidence of transmission of tuberculosis via ventilation system, and I think the reason may be that the infectious dose is actually quite low for tuberculosis. For COVID, it may be a bolus of virus that is needed, and in that case, a dilution in the ventilation system, except perhaps on a cruise ship, may be a mitigating factor against transmission through ventilation system. I'm not seeing reports in buildings, for example, of spread through ventilation systems so far. But any other comments on that point before we move on? Well, thank you. So we've moved into now the impact of COVID-19 on tuberculosis reporting and care, and a number of solutions to that, which I think this symposium has held together quite well in terms of telling a very nice story. So we began with Japan, and I would like to ask our author, who focused really on notifications, if he has any insight into the impact of those notifications on ongoing transmission, for example, as we heard in some of the other talks, or impact on effectiveness of treatment.
Yeah. Sorry?
Yes, go ahead.
I cannot hear it, sorry.
Okay. Oh, you didn't hear my question?
No, my network is sorry, a little bit.
Okay, go ahead.
So, yes, I can't hear it clearly, so please repeat that.
Okay, I'm repeating the question. I was asking, you focused on the notification rate in Japan, impact of COVID, very impressive. And we've heard that also in a number of other settings. I'm wondering if you had any sense of the impact of reduced notifications on ongoing transmission, or effect on treatment.
I have no exact answer. So sorry. So some reason of the decline is really decline of the infection between the person to person. And also, I have some report from the health centers. They're delayed to the procedure of the, for example, inputting the surveillance system and some registration, and so I have no exact reasons.
And any other questions for the speaker, Dr. Ushimura? Kirtan, do you want to deal with this next talk?
Yes, thanks. Thank you, Ed. So the next talk, I think Rebecca Harris is with us. And the next talk was really focusing on COVID and TB disruption. It was a modeling study. And Rebecca, maybe I could ask you to talk about two things. One is smoking and TB, and whether you thought about that and introduced that into your model, because smoker is a big driver of TB in Africa and well, many countries. And in South Africa, we had a hard lockdown, and we actually had banning of tobacco smoking, at least in public. And some people thought that that would actually drive the COVID epidemic because of sharing of cigarettes and so forth. But as you know, smoker is a big driver of TB, so I wondered about that. And the second thing was really about poverty itself. And in many countries, in resource-poor settings, the hard lockdown had quite a tremendous impact on the economy. I mean, the South African economy shrunk by over 50%, unemployment hugely up, and there's estimates that that has going to cause a huge impact on TB itself, just the poverty aspect of it. And so I just wondered about those two things and how that might have affected your results, and particularly the poverty part and the economic downturn, whether you think that your results really have been, or the impact has been grossly underestimated. Over to you.
Thank you very much for those questions, Kirtan. They're both very important points that I'm glad that you've addressed in this Q&A. So in the modelling work that we did, we very much focused on some hypothetical scenarios of social distancing and disruption to TB services. And from many of the other speakers in this session, we've heard really interesting examples of, in different countries, those disruptions to TB services and potential solutions. So in terms of your first question for smoking and TB, it's not something that we explicitly included in our model. And it would certainly be something that would be interesting to explore in further research. As you say, it could be that sharing of cigarettes could have increased transmission. It could be that changes in smoking behavior. If there's a ban, people smoking less. If there's people being bored at home, maybe people smoking more. And so it could be interesting to explore what changes in smoking behavior, and certainly other things as well, alcohol intake and things like that, other behaviors that might be associated with TB burden. It'd certainly be interesting to explore that. But wasn't explicitly explored so far in this model. And then the second question with regards to the poverty impact of COVID and the impact that that might have on TB, again, something that we haven't explored in the model, but that would be very interesting to do so, as I think there'll be plenty of examples where the increase in poverty due to COVID-19 disruptions could have an impact on TB. And so certainly, if we introduced the different quantiles in terms of income into the model, then that's something that again could be explored in future work. But both certainly for poverty, the poverty aspect, we've probably underestimated the impact of COVID-19 disruptions from that perspective. Thanks for those questions.
Yeah, thanks, Rebecca. Any other questions or comments for Rebecca?
Yes, Kirtan, I have a couple of your talk, Rebecca, stimulated a number of thoughts and questions, mostly because it really takes us directly into the interaction of these two infections. There's been some recent talk about how quickly one develops tuberculosis after infection, and you talked about transmission-driven versus, I guess, reactivation-driven scenarios. But if you believe Marcel Baer's recent work on that most patients reactivate within a year and a half of infection, then most of the tuberculosis we're seeing, with definitely some reactivation in low-burden settings like the U.S. And other places, may be transmission-related. If we were to push toward a more transmission-related model, then presumably your study would show a greater impact of social distancing and reduced airborne transmission on overall outcomes. Is that true?
Thanks, Ed. So yes, so if you look at, in terms of each of those settings, so China, South Africa and India, in terms of whether they're reactivation or transmission driven, in the models, China is more reactivation driven, South Africa is somewhere in the middle, and the fitted model for India is certainly more transmission driven. And so if it were to hold that you were thinking about settings that were more transmission driven, you might expect results that were more similar to India.
And you didn't include a COVID TB biological interaction feature, and I'm wondering if you or anyone on the panel would deem to speculate what that might be. Would COVID increase the rate of reactivation or transmission by virtue of coughing, for example? Would it or decrease again, either through social distancing, or it's hard to imagine how the COVID would reduce tuberculosis, but I raise the issue.
Yeah, as you mentioned, we didn't include anything from the biological perspective of how there might be an interaction between COVID and TB. I don't know whether any other speakers have any thoughts on that.
And what about competitive death? In other words, you only die of one thing. And I'm thinking back to the 1918-1919 epidemic, which enormous mortality. As bad as things are today with COVID, things were much worse then, and we didn't have all the abilities to maybe electronically get around some issues like we've heard about. If you died of a flu, those would certainly have been some COVID, some tuberculosis deaths at a time when TB was much more rampant. What do you think about that? What's that interaction do to our rates of TB, do you think?
Yeah, again, an interesting point that would be interesting to explore with further modelling. But again, that would be dependent on whether the likelihood of death from COVID is different between those who have TB and those who don't.
Yeah.
I mean, just to chip in there, just to give you our experience from South Africa, both at national and provincial level in the Western Cape, if you had a diagnosed with active TB or had a history of previous active TB, then your mortality was twice as high as someone who didn't have those risk factors. And certainly in clinical practice in our wards, we've seen many patients with COVID-19, particularly in the ICU, who also turned out to be TB positive. Having said that, although we have tested some people, I think there's a gross underestimate of the co-infection rate, because whilst we tested for COVID-19 quite extensively, we hardly ever tested for TB. For obvious reasons, often you couldn't get a sample was the simple reason. So yeah, I think that's a very interesting interaction. Just one last quick comment. There was an analysis here in South Africa where they looked at the number of deaths during the lockdown related to the economic impact of the lockdown versus the deaths that would have occurred if there was no lockdown, i.e. from the surge on the hospitals and people not getting adequate care. And it was a modeling study, and the estimate was that the deaths would be at least at the minimum, with very conservative estimates, 50-fold higher from the economic impact of COVID-19 compared to people who would have died from the surge if there was no lockdown. So just a quick comment for you there. All right, well, thanks for that. If there are no more questions, I guess we can move on to the next talk. Ed, is that yes, okay?
And actually, the next two talks are from Nigeria, and we heard first about the reduction in case finding in Nigeria, and then actually some explanations for that. So first, on the reduction in case finding in Nigeria, I would again ask a question that we asked of our Japanese presenter. The impact of that on TB control, and any insights on what's happened to TB control, ongoing transmission? We think diagnosis and treatment is the main way that we stop transmission. If you're not getting case reports, you can't start treatment. And any insights further beyond the impact on case finding?
Okay, yeah, thank you very much for that insightful question. Yeah, we actually looked at the TB cascade. Now, there are two things that could have actually contributed to key of our findings. One is that there was decreased hospital attendance. Now, for facility-based TB programming and passive case finding, we look out for TB when the clients come to the facility. Now, using the TB surge as an example, where KNCV with the funding from USAID, we stationed cough officers across high-volume facilities. These cough officers can only screen when the patients attend to the facility. Now, with the lockdown restriction, there was decreased access to care, and fewer number of people were coming to the facilities, and fewer number of people are reached. Once that primary denominator was low, across all the cascade, the number of presumptive that will be identified, number that will be evaluated, number of cases that will be diagnosed, everything was on a downward trend. Now, another contributor was actually the issue of stigma around COVID itself. At the initial time of lockdown and the COVID epidemic in the country, there was this association: once you have COVID, you are isolated, put in isolation center, cut off from the families, and the burial rites, looking at our cultural setting. Once you die of COVID, your family will not have access. Even at the few that may come to the facility, they hardly own up to the presumptive symptom of cough. Even when they ask, oh, do you have cough? They see that association between cough and coronavirus, and they will not even tell you that they have cough. Most cases that were picked up in the facility are actually clinical diagnoses. 14 hours. Now, once we are not picking the cases in the facility, where are those cases? If they don't come in the facility, they're actually in the community. And we know that TB as a case, once a case of TB not picked up, not diagnosed and put on treatment, can actually infect close to 15 to 20 people in a year. Now, once those guys are not coming to the facility, they're actually transmitting the TB disease within the community. And to be very, very sincere, some community-based active case finding intervention were yielding good results during that COVID lockdown. Because people are sick, they must seek for care. They don't come to the facility that they're transmitting.
I need to interrupt you because we actually have just a couple of minutes left, and we have two speakers left. Could you, who are here, Kirtan, do you want to move on to the next speaker, which is also Nigerian, I think in a similar vein?
Thank you.
I just unmuted myself. Sorry about that. Well, no matter how many webinars one attends, one never gets it quite right. So I think the next talk was, as you suggested, it was Dr. Ogwu. I hope you pronounced your name correctly. And it was all about the willingness to test for TB, and there was a low willingness to test. And so maybe he can tell us, this lack of willingness to test. In your view, if you break it down in the granular sense, what was the actual fear? Was it a fear, or were people embarrassed? Because on the other hand, if they were diagnosed, obviously they wouldn't transmit disease, they wouldn't put family members in danger and so forth. So maybe you can comment, at community level, what was the actual fear and the embarrassment? And on the other hand, how did people process all this compared to, potentially protecting their loved ones from getting COVID? Over to you.
Apparently, we're going to be leaving because of the time.
Yeah.
Apologies to the speakers that we did not get to.
He had some challenges with his network.
All right, so we have to say goodbye. This is what our producer is telling us.
Thank you very much. Thank you very much for those questions. Quite a while. So yes, hello. Can you hear me?
Yes.
Yeah. Go ahead.